Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts. Hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, I'm Dr. Michael Koren, the executive editor of MedEvidence. And we have a really special podcast today. I get the opportunity to meet lots of different people and talk to different people through these podcasts. But I have to admit, it's always the most fun for me when I have a kindred spirit or a kindred soul to talk to. And today I'm going to be speaking with Seth Baum, who I think qualifies for that. And Seth and I have known each other for a long time. He's a fellow preventative cardiologist, although has a history of also doing interventional cardiology. And he and I have been very involved in a lot of research together over the years, including multiple publications together. And I want to invite you, a warm welcome to MedEvidence, Seth, and we're going to have some fun talking about trends in cardiovascular disease and really some of the important elements of clinical research about how to keep patients engaged in ththese trials.
Well, it's
Welcome.
Great to be here. I hope you don't hold my interventional cardiology background against me. It was a good period of my life, but preventive cardiology is certainly a better one. So
Okay.
It's great to be here to talk to you.
So a lot of people are listening to this don't understand all the nuances, but like every other field, cardiologists come in different flavors, and we all love each other, but we have these internal debates, these little sibling rivalries within our profession. So interventional cardiologists are a little bit different than preventive cardiologists, who are a little bit different than heart failure cardiologists, who are a little bit different from epidemiological cardiologists or EP electrophysiologists. So we all have our little niche, and we like to tease each other on occasion about the pluses and minuses of our niches. So thank you for that, Seth. So Seth, tell the audience a little bit about your background and where you got to where you are today, which is a leading expert in preventive cardiology. In fact, president of an important society, past president of an important society that deals with these issues.
Yeah, so as you noted, I started in interventional cardiology and actually electrophysiology as well. So I had both of those fields. And around 2000, I totally shifted my focus to lipids and cardiovascular disease prevention. And I grew in the fields. I learned a great deal. I've had a good time helping educate as well. I was the president of the American Society for Preventive Cardiology. I'm currently the chairman of the board for the Family Heart Foundation, which is a nonprofit that focuses on familial hypercholesterolemia and Lp(a). And then, as you know, I started a clinical research site just under 10 years ago in Boca Raton. Then that became Flourish Research. I'm the chief medical officer of Flourish Research, and you, of course, are the chief scientific officer. So now we get to work together after having known each other for quite some time.
Yeah, it's been fun. So we're both working in this network of sites now that are represented throughout the country. I'm in Northeast Florida, and Seth is down in South Florida. So it's been a fun journey, and the journey continues. So thank you for that, Seth. So let's talk about the macro issues in cardiovascular disease, and we're both driven by the fact that during the course of our career in cardiology, we've seen a dramatic drop in cardiovascular death rates. So those of you who are non-cardiologists or are not familiar with the data, the death rate for cardiovascular disease peaked in the United States in the late 70s. And between 1980 and around 2012 to 2015, there was a dramatic drop in cardiovascular disease death rates in our country. And this death rate sort of bottomed out around 2012, 2015. And unfortunately, over the last 10 years, it's ticking back up. So during this drop of 30 plus years, we saw a 60% reduction in cardiovascular disease mortality in the United States. Truly remarkable. It's one of the most incredible stories about the success of the healthcare system. But equally remarkable, in the opposite direction, is the fact that we haven't made progress in the last 10 years. So let's start the conversation, Seth, by giving the audience insights into why we've stalled. Why do we stop making progress?
Well, I don't think anybody knows for certain that there's one specific thing that has caused this this shift. But we can look at risk factors that predispose to cardiovascular disease, to cardiovascular events and death, and we can see what has happened with those risk factors. For example, one thing that can be attributed to the great improvement would be smoking cessation that occurred. There was a strong smoking cessation push during those earlier years. It was very effective. Dietary changes were implemented that were effective.
And changes in the food industry. The food industry was selling different food.
Totally different food.
Yeah.
And frankly, the American Heart Association and other organizations were supporting different foods at that time as well. So there were a number of influences. People were lighter, less heavy. They were exercising, and the country was in this preventive position, if you will. Some things shifted, right? The American Heart Association made a shift in its dietary recommendations that, some might say, have helped lead to an increase in weight among Americans. This focus on carbohydrates at the expense of fats maybe became a little too extreme, and people started gaining weight. And of course, with weight gain came diabetes, came inflammation, came increased fibrosis in various areas such as the heart, and there are a number of factors that occurred there. I'll stop now and give you the opportunity.
I was going to say, and hats off to our interventional colleagues who have helped reduce the mortality rate of acute MIs. So when we started our training in the late 80s, the heart attack death rate was north of 20%, and now it's considered less than 5%. So there's been huge advances in terms of acute care. ICUs are much better than they used to be. So when you get sick, we're much more likely to bail people out than we were 30 years ago.
That's very true, and I, as a former interventional cardiologist, of course, should have highlighted that. So thank you. But that is very true, and of course, we have new medications that reduce cardiovascular event rates. Lipid-lowering therapies have, of course, improved. We have many studies to demonstrate their effectiveness. So there are a lot of medical and interventional approaches that have helped that very dramatic decline in cardiovascular event rates. They're now being offset by those shifts, I believe, in diet, in weight, in diabetes, in NASH, or MASH, I should say, and heart failure, and so many other things.
Right.
So I think that's
I think we should also point out specifically that statins probably had a huge impact in improving cardiovascular morbidity and mortality. And during this period between, let's say, the late 80s and the early 20-teens, there were statins on the market that were being promoted by the pharmaceutical industry. So we were constantly being reminded by salespeople, basically, from the pharmaceutical industry to get the cholesterol down, use these drugs, and they worked. And we did a lot of cardiovascular trials. These are huge outcomes trials now that show that people who were involved in these trials comparing statins with placebo or high doses of statins versus lower doses of statins did better. And it was unequivocal. And unfortunately, I think that message is getting lost a little bit. I don't know if you agree with that.
Yeah, I would just say that's a really interesting point about the pharmaceutical reps. I remember a statistic that 5 years out from our training, the greatest education used to come from the pharmaceutical reps. And of course, that was then frowned upon. And there are physicians who don't allow them in their office today. Yet we were learning a lot, and it was top of mind. So that brings up the fact that today, after an acute infarct, a year down the road, less than 50% of people are actually at goal, and maybe 70 or 80% are not at goal. And some
lipid goals. We're talking about cholesterol and lipid goals. Yeah, goal. Yeah,
correct. And in some studies, 50% are not even taking their statin, or any lipid lowering therapy. So, that's another part of why we're falling short. We're not treating the patients adequately who we could be treating.
Yeah. Yeah. Were you involved in the Victorian Initiate study? Remind me of that.
Not the Initiate.
Yeah. So I was the lead PI for that, principal investigator for that. And that was remarkable. That was a different study. Instead of using a placebo-controlled, we had a, quote, situational control of usual care versus aggressively using advanced therapy when patients were not at their LDL goals. And we found that only 7% of people in usual care got to their LDL goal, despite the fact they were in a clinical trial and despite the fact they were being reminded over and over again during the course of a year. So that just shows you that there's a lot of inertia. And I think that's fundamentally changed because there's not as much discussion about that in the doctor's office the way there used to be 20 years ago.
I think you're correct. The Family Heart Foundation has some data showing, around 20% or so of individuals, a year out from acute coronary syndrome are at their goal. So, and it is, there are multiple stakeholders involved in this issue. We have the payers who push back on some of the therapeutics we can use. We have physicians who have clinical inertia. We have our guidelines that in 2013 gave us basically the wrong message, sent the wrong message, and we're trying to recover from that. So we have patients who are seeing things on the internet that are making them feel that these medications are not for them for a variety of reasons. So multiple problems that we have to confront.
Right. So I guess the good news is that we're working hard to offset that. So both you and I are very involved in clinical research, trying to make it simpler to get your cholesterol levels down, trying to treat targets that we couldn't treat before, such as lipoprotein(a), and also making compliance easier for people by using longer acting products. So maybe you can tell the audience a little bit about some of that work.
Yeah, no, I think, frankly, you just did that. So there are multiple trials. If you talk about Lp(a), there are multiple drugs in development. Lp(a), for the audience, if you don't know what it is, it's like a really bad kind of LDL. It's a smaller particle. It increases inflammation, increases thrombosis, it increases atherosclerosis. So it's a triple threat, we say, highly prevalent, 20% of the population. Blacks, 30% of the population. South Asians, 25% or so of the populations. And frankly, Hispanics maybe a little lower than the 20%, but very highly prevalent and very tightly correlated with event rates. So we've done a number of clinical trials. There's a few phase 3 studies ongoing right now, and hopefully we'll get to the point where we have a therapeutic in the not too distant future to address and solve the problem.
Yeah, so these are very, very important studies that are going on. And as you alluded to, these are studies that run over an extended period of time. And so one of the challenges for a clinical investigator is to keep their patients engaged and involved in the study, especially when they're placebo-controlled studies where certain members of the population won't be on an active therapy. And quite frankly, nowadays, you can kind of cheat and figure out what you're on. And that is a phenomenon that we have to deal with. So why don't you explain that a little bit to the audience and why this is such an important issue for clinical investigators?
Yeah, well, first, the overarching cardiovascular outcome trial, it's important to understand that type of study. That's a study where we typically use a placebo and compare it to an investigational product, a drug that's in development. These are very long studies. We're looking at events, typically heart attack, ischemic stroke, cardiovascular death, sometimes hospitalizations or interventions. So we look at these event rates, and it takes a long time for them to accumulate. And frankly, we don't want the studies to be truncated or too short, because sometimes in that case we might not see all of the potential benefits that can occur. So these are from a statistical standpoint, have to be very carefully planned and executed. So that's basically what the cardiovascular outcomes trial is. We need people to stay in. We need people to take their medicine. We need people to be blinded, not to know what they're taking, and then to complete the trial to get the best results. The problem in as you mentioned, in some of these lipid and lipoprotein studies, like Lp(a) or LDL studies, is that patients sometimes can go to their physician's office and get their lipids drawn or lipoproteins assessed, and they can figure out whether or not they're on drug. If they respond to that by either dropping out of the study or taking an additional medication that they're not supposed to take, it clouds our data. It makes it harder for us to understand what's going on.
Really, it compromises the whole experiment.
Right.
Yeah. So, Seth, let's take a quick break right now. And then on the other side, what I'd like to talk about is specific strategies to keep people in studies, starting from the very beginning of their enrollment. As experienced clinical trialists, I think we might be able to have some insights that we can share with other people.
Sounds great.
To continue watching this podcast episode, head over to MedEvidence.com.